Our healthcare leaders in healthcare organizations, institutions, payers, wherever they are, need to remain the gatekeepers to ensure that implementing new technologies doesn't happen too quickly or for the wrong reasons, and that it adversely affects patient care.
Hello, this is Zach with the American Journal of Healthcare Strategy, and you are listening to the Clinicians in Leadership podcast, where we focus on empowering clinicians from bedside to boardroom. Today, we have the pleasure of being joined by Dr. Tim O'Connell. Dr. O'Connell, why don't you take a second to introduce yourself, share a little bit about your experience and your current role, and the ways that you're serving now?
Thank you, Zach. Good morning. It's very nice to meet you, and thank you very much for having me on. As you mentioned, my name is Tim O'Connell. I'm a practicing radiologist. I'm based in Vancouver, British Columbia, in Canada. I've been practicing medicine now as a licensed physician since 2012, and I work at a number of different hospitals here in Vancouver. I work clinically 1 to 2 days a week, and the rest of the time, the other 9 days a week, it seems like, I'm CEO of a medical language AI company called Emtelligent. We started the company with some partners about 8 years ago now to solve some of the problems that I certainly see in healthcare with unstructured medical text. And that's, the thousands and thousands of reports that every hospital generates every day, and clinics and things like that, where there's, tech prose text that a caregiver has dictated or typed or created. So, yeah, it's been quite the journey and quite an exciting time for us right now. And before going into medicine, I used to work as a network engineer. So I got a master's degree in engineering, and I worked for both a large equipment manufacturer and a large telephone company, doing networking and working in information technology. So I've been able to combine my love of medicine with my love of technology, and every day is a great day in the candy shop.
Yeah. Well, Dr. O'Connell, we are thrilled to have you on today, and particularly just to discuss this topic of AI. And we're going to dive through some questions, kind of focusing on AI and some impacts that can have on the medical community. But I think your background is allows you to speak to this in some very unique ways. I mean, you've mentioned still practicing medicine, serving in an administrative capacity, as well as your background as a software engineer. Like, holy cow, that's the combination of that background is just the perfect setup for this topic today. And so I'm excited to dive into this. And so as we get started, as someone that has served in the IT world, in the software world, in the medical world, and in the administrative world, how do you see AI shaping the future of patient care and operational and organizational efficiency?
Well, thanks, Zach. So I think that's definitely kind of a crystal ball kind of question, and I love answering those. But to paraphrase Bill Gates, many years ago, he said, I can predict where we're going to be 5 years from now, but 10 years from now, I have no idea. And in AI, the landscape is moving so quickly right now. I think I can predict where we're going to be 5 months from now, but 10 months from now, I have no idea. But I think it's going to change care in sort of three areas. One, I think right now, compared to a lot of other organizations like manufacturing and things like that, I think in healthcare, I think we have relatively poor organizational efficiency. A lot of our workflows are very manual. It's a human doing a task and handing it off to another human, and there's all kinds of efficiencies there. So I think AI systems for finding problems in efficiency and fixing them through automation, I think there's a lot of room there for improvement. I think we're also going to see another area for improving efficiency is just automating monitoring of patient outcomes and stopping problems before they start. For example, if a patient gets an infection while they're in hospital, it's going to massively increase their length of stay. So having tools that can automate monitoring and solving problems like that, I think will be great for improving efficiency, shortening length of stay, things like that.
Yeah.
Really, I think another area that's going to be really important is just general improvements in clinical medicine. I think there was a really interesting study, which was just sort of, I think it was posted in JAMA or maybe the New England Journal. And it sort of said that a large language model was able to do a better job diagnosing complex patient, disorders essentially, or diagnoses, than humans were, and was even better than human and large language model alone. So I think we're going to see him, and those complex cases that come into the hospital, and it takes 2 weeks to understand what's going on with the patient, the sort of host episode. Those cause a lot of problems and efficiency, and so I think there's real areas for improvement there.
Well, and Dr. O'Connell, I'm interested in hearing your thoughts on this next question. You've mentioned in that previous answer just the rapid rate at which AI is developing and progressing and becoming more commonplace, and that really is true if you look back over the last number of years. It's becoming more commonplace. It's becoming more common practice, becoming more accepted. Yet there still is some barriers to the adoption of AI and seeing the usage of AI and trusting AI. And I want to dive into that a little bit. But prior to diving into some of the specific things that we'll cover later on, I'm interested to hear from you with your experience and your background. What are some of the biggest barriers to the adoption of AI in healthcare? And how can organizations overcome those barriers?
Sure. I think one of the big barriers is the products have to actually work. There's a lot of sort of froth and excitement right now in a lot of areas where people going, oh, I can use this large language model to diagnose something. And that may work on a one-off kind of scenario, but then when you use them to deal with millions of patient reports or things like that, you may find that the accuracy is unacceptable. I've seen lots of trials of even things for generative use cases, like generating discharge summaries and things like this at hospitals, really go off the rails because the products don't work for that use case. So I think that's one of the issues. I think one of the other issues is a lot of the use cases for AI involve workflow changes and job changes, and there can be many, many reasons why those products are taking time to adopt. Right? You can't go into an organization as complex as a hospital where if you change one thing, there's all these downstream effects, the sort of, butterfly flapping its wings in Brazil kind of effect that, there can be unintended outcomes and consequences. So implementation always takes a long time because everything has to be done safely. You don't want to be like, oh, we improved efficiency in this area and then have all these like bad patient outcomes in another area. I think one of the other issues is security. I think in using AI, some of what we're seeing from, and I have some personal experience in this, in some of what you see in when you go to use a large language model is that some of the hyperscalers can be fairly opaque about how they plan to use your data, right? And well, we'll retain your data for 30 days, but we're not going to use it. And what does that mean? And this sort of thing. So I think there needs to be more clarity on how some of these companies that if they're hosting models and this sort of thing, that how they can use their data. And finally, I think one of the other big adoptions is for some of these projects, I often tell people that AI is capable of really cool party tricks, but that doesn't mean that there's a good ROI for the investment you have to make to actually be like, oh, we should implement this, because there may be a massive implementation cost or an opportunity cost to implement a new system. And at the end of the day, it doesn't actually save you money or produce efficiency. It's just like, well, we did it because it could. So I think those are sort of the four areas that are slowing down adoption right now.
One of the areas that you mentioned is just the products have to work and they have to work well, and they have to accomplish the goal, and they have to be safe. And another common barrier that I think is felt more in the organization sense is a lack of trust among your clinicians and your frontline staff who are actually going to be using those products to help inform their patient care. And that's understandable, as you've had, and with an aging population and an aging and growing, an aging provider population as well, who have served in these patient care settings for a wide variety of years. And just in the most recent years, AI is becoming to the point where it could be helpful. And so, how can clinicians and physicians and leadership build trust among clinicians that work in their organizations and among patients in the decision-making capabilities of AI?
Sure. So I think one thing's worth addressing right off the bat for the audience, and that's, I really don't think there are any doctors out there who are like, or a very, very small number of physicians out there who are like, oh, I don't want to use this thing because I'm worried about it stealing my job. Right. I don't think it has anything to do with that. I think a lot of people have used sort of AI products or workflow augmentation products in the past and had bad experiences of them with them, and so they're very wary. If you used computer aided detection tools 20 years ago, in at least in radiology, you might have been like, oh, like, these were as wrong as often as they were right. And but there has been 25 years of progress since then, and things are better now. But I think that, really how you get to have trust by your care providers in these products is through really well run proof of concept projects and really well run pilots. And really clear goals. In medicine, we're all about, like, that there has to be all this rigor around experimental testing. There has to be ethics review. Establishing non-inferiority is often the goal. And so we need to approach implementing changes in workflow the exact same way. It really has to be that, we're being rigorous and we're being careful when we're implementing new workflow solutions, not to just swap stuff out. And I think another area that I think clinicians need to see from their leadership is no conflict of interest. I think, it's often, people have made accusations in the past about people in the military that, by the time they get to be a general, they're really just auditioning for a job with a defense contractor. And I think the same thing is true in healthcare leadership. I think that leadership in healthcare organizations, often they're willing to go and sign, large agreements with large hyperscalers to say, oh, we're going to give all our business to this one giant hyperscaler. And you're sort of like, that doesn't make any sense from an organizational perspective, from a patient care perspective. It's like, why did you do that? Were you auditioning for a job with them? So I think that we need to be very transparent about potential conflicts of interest, conflicts of commitment is in healthcare leadership.
Well, and Dr. O'Connell, I think that this next question kind of comes off of that previous question a little bit, and so I'm curious to hear your thoughts on this one. Um, how can your physicians, your physician executives, your clinicians and leaderships, uh, champion these AI driven initiatives while ensuring that the alignment of the broader organization and the goals of the organization and serving the populations and the patient populations that they serve, how can how can your physician executives ensure that those line up? Because, like you said, you've mentioned before, AI is really good at doing party tricks, but how can you make sure that it's not just a party trick, but actually, no, this is benefiting the patients and the populations that we're serving, and also benefiting the organization as a whole? How do you make sure that balance is there?
For sure. I think, people are familiar with Maslow's hierarchy of needs, right? For bottom line, we need sort of shelter and food and things like that. Use absolutely a hierarchy of needs in healthcare and in project implementation. And the number one hierarchy is the patient always comes first.
Mm.
Absolutely. There can be no negative impact on patient care. And if you're going to do a whole lot of work to implement new systems and workflows, then there actually should be a net benefit to patient care, right? Either an improvement in quality of care and safety of care or efficiency of care. And so that's always the yardstick, right? The next sort of step in the hierarchy of needs, I think, is the sustainability of care. Are we implementing a system which is going to adversely affect how sustainable our care is, right? Is it going to create an extra hour of work for one of the caregivers involved in the patient workflow? Then we need to look at it and go, like, this may result in people quitting jobs or changing jobs. And so this is going to be a net negative impact, right? And then we also have to then look at organizational sustainability, profit, ROI, things like that. So I think by always making sure that we put the patient first, I think that is the most important thing to ensure alignment, and not just doing stuff because we can.
And that just speaks to the importance of having someone with that clinical experience in the room and being a part of that decision making process, because they have tangible numerous years of experience of keeping that patient first, and interacting with that patient and doing what's best for that patient. And so,
Yeah, absolutely right. And I mean, this is the history of technology implementation, right? Is you can always implement new technology to replace humans, but you have to be careful about it and smart about it, and make sure that you're not sort of, you know um, creating an adverse outcome somewhere along the way.
a common phrase, Dr. O'Connell, that we hear a lot nowadays is that we're entering into this era of personalized medicine, and just that that's just a common phrase, maybe some buzzwords that are being thrown out a lot. And but really with it, some more of the recent innovations that seems to be more of the case. Um, with that, we're entering this era of personalized medicine. And we are also becoming more and more aware of disparities in healthcare, and equity in healthcare delivery, and where those disparities in equity don't line up. And so I'm curious, with these innovations and tools, particularly with AI, how can clinicians in leadership use AI to address some of these healthcare disparities and improve equity in care delivery? How can your healthcare leaders drive these initiatives and drive innovation that really addresses those areas of need?
That's a great question. I think it's one of the most pressing questions of our time in healthcare is how can we reduce disparities in healthcare delivery? Absolutely. Um, the very short answer is I'm not exactly sure. I think that it is an incredibly important question. I don't think we're at the stage yet where we always know what the problem is. I think that in recent years, healthcare organizations have made tremendous steps forward, but quite arguably not enough to listening to people in marginalized communities, right? I think, and I've met many patients in marginalized communities, and they don't even want to seek care because they've had such negative experiences in the past when trying to obtain care. And so I think we have some fundamental problems with our healthcare systems and our healthcare delivery models that need to be addressed first, for providing care to people in marginalized communities to obtain their trust and get them even coming into the healthcare system. And due to cultural differences, maybe having 1,000-bed hospital with an intake area that looks like you're going into a conveyor belt in a factory isn't the right system for some of these people in these communities. And so um, I would love to have, I'm hopeful that we can start using AI in smart ways to help address disparities in healthcare. Um, but I'm not sure. We have this fundamental problem of people not even seeking healthcare that we need to solve first. But I think that's a bit of a separate question from the topic of like how can we ensure a lack of bias and equity when we are training models, and I think we still have more work to do there, but it's certainly, I think, training on, you know, training data, not just on what's available, but rather working with organizations to ensure that you are training on broad selections of data, um, from people with different backgrounds, so that you can, make your models aware of all the, enormous genotypic and phenotypic differences that exists in humans today, let alone differences in the social environment and professional environment that can overlay with these things. I just had a clinical case where I looked at a chest X-ray, and I'm based in Vancouver. We have a very, very small population of African American individuals here and people from West Africa. And I looked at a chest X-ray, and I called the emergency room doctor, and I said, I think this very young patient has sickle cell anemia. And he said, how can you tell that? Why would you even think about that? And I said, well, I trained in the U.S. Northeast, and there's some signs here, and in where I did some of my fellowship training, that's a very common disease, right? But here in Vancouver, it's extremely uncommon, and so there's just general unawareness of it. And so that emergency room doctor was very thankful and worked the patient up, and they were positive. But it's just an example of where geography and background and what's in your training data can make a huge difference to patient care.
Well, and I think one of the things that I loved just throughout that answer is the importance of that human connection in healthcare, and the importance of just not necessarily important, but the benefit that a caring provider can have on a patient to encourage them to return to seek care. And like you said, there's fundamental issues that need to be addressed with just building trust with the healthcare systems as a whole, and that's a topic for a whole nother interview and another episode that we can dive into another time. but but in particularly just the benefit that the tools that recent innovations such as artificial intelligence can provide. But ultimately it does come back to that: can the provider build that trust with that patient to encourage them to return? And I think that is such a critical component, that is often we are looking for AI and other things like, hey, let's fix this issue. When in reality, like you identified, and I think identified correctly, there's a lot more fundamental issues that we have to address. AI can help, innovation and tools can help, but it's not just going to be the band-aid that fixes everything. I mean, quite literally could be a band-aid to cover up some issues that we still need to address later on. And so Dr. O'Connell, shifting gears just a little bit, we've mentioned a number of times just the rapid advancement that AI has undergone over the past number of years, and how you've mentioned that you may be able to predict where AI is going to be in 5 months, but past that, who knows? And that is both exciting from a perspective on ways that could impact the medical field, but also terrifying, I'd imagine, to leaders that are trying to make decisions and evaluate data and stay on top of an ever-changing field. And so how do you keep your organization prepared for these rapid advancements while still maintaining focus on the everyday responsibilities of taking care of patients, and doing just the regular organizational tasks that you need to do?
Sure. I think one of the nice things about medicine is that it turns out there's only usually one sort of right answer when you're talking about like answering clinical questions, right? Like the patient has diabetes or they don't have diabetes, right? But so one of the ways which we, are able to very rapidly use new technologies and yet still maintain that focus is through good, high quality benchmarks. And so these could be, data sets that have been human annotated as a gold standard and then testing new technologies against them as they come out. Now, I think one area that the industry is very much still struggling in is large language model benchmarks. I've yet to see, I think there was just some published in the last month that I'm hopeful are higher quality benchmarks. But at my company, we've done a deep dive into a lot of these benchmarks and found that they are extremely low quality benchmarks that, you know, there was a movie years ago, which I think illustrates it very well. It was called Catch Me If You Can. And it was about a famous, a notorious fraudster, a gentleman named Frank Abagnale, who later turned his life around and now does all kinds of great things. But in the movie, and it wasn't in his book, he passes, I think it was a Louisiana State bar exam, right? And so the question is, well, he passed the bar exam, is he a lawyer? And so you'd have the same question of, well, you passed your USMLE step 2 medical licensing exam. Does that make you a doctor? And the answer is, of course, no. And so we're seeing, some very low quality benchmarks being used to test models, and then we're seeing press releases. Oh, this model so-and-so passed the USMLE step 2. And it's like, that's not what makes someone a physician, right? You don't get to operate on people, or you don't get to read chest x-rays just because you passed a background knowledge examination. And my goodness, those models have been trained on like hundreds or thousands of medical textbooks. If they can't pass those medical licensing examinations, then that means they're missing the mark by a wide margin. So I think benchmarks are going to help us stay focused on what the right answer is and ensuring that new technologies can meet them. But we need better benchmarks than we have right now. And that's actually something we're actively working on.
Dr. O'Connell, I'm grateful for your time today, and just excited to just learn a little bit more about AI and how it can benefit healthcare, and just dive into the topic that we've covered today. Before we go, just one final question, and then I'll let you go, I promise. What advice would you give to fellow clinicians in leadership about staying ahead in an AI-enabled healthcare landscape?
Sure. So number one, I think you shouldn't feel bad if you find that things are moving too quickly and you're always feeling like you have to catch up, right? I think what happened this week with DeepSeek was a great example of that, right? Like we've sort of known about them for sort of months now, but then, I think the bombshell got released and everyone was like, whoa. And, you saw that reaction in the stock market as well. So, don't feel bad. It's moving quickly for everyone. But I think the advice I have is like, you have to be the gatekeeper. Remember that there's a lot of people at these companies with good intentions, but no clinical experience or poor or limited clinical experience. Uh, and, someone's opinion that their product is going to help patients doesn't mean it's actually going to work. So, our healthcare leaders and healthcare organizations, institutions, payers, wherever they are, need to remain the gatekeepers to ensure that implementing new technologies doesn't happen too quickly or for the wrong reasons, and that it adversely affects patient care. And so they should be very secure in that.
Well, Dr. O'Connell, I love that answer, and in a sense, your clinicians and leadership are grounded by that. That gives them something that they can compare every opportunity and every new innovation. Take it back to, hey, how does this impact patients? How will this benefit patients? How could this negatively impact patients? And in a sense, I think that your clinicians and leadership have a little bit of an advantage there, because you have that focus, and you'll maintain that focus, and you're not going to. It's harder to get a little bit dissuaded by the other opportunities that are out there. I'm distracted by the other opportunities out there. And so, well, Dr. O'Connell, thank you so much for joining us today on the Clinicians and Leadership Podcast, and we wish you the best. Thank you so much.
It was my pleasure, Zach. Thank you so much for having me on.